Good afternoon, people who are signing on. We're about to get started in a couple of minutes. We have a lot of people who've registered. We're just waiting for them to sign on at 1 o'clock or whatever time zone you're in. So we'll get started in a couple of minutes. Okay, we'll get started. It's 1 o'clock. And as people are signing on, I'll introduce myself and get started with today's webinar. My name is Jay Sackman, and I'm a member of Advancing Excellence in Long-Term Care Collaborative. I was a chair a number of years ago, and I've been associated with Advancing Excellence, I guess now for 18, 19 years. Next slide. So as you can see, Advancing Excellence is a forum for government, professional, consumer, trade, and clinical and other stakeholders to take collective action and develop policy recommendations around vital issues affecting quality of care and life for individuals receiving acute and long-term services and supports. The members of Advancing Excellence strongly believe that the collaboration among all stakeholders in post-acute and long-term care is a powerful and effective method for driving change and positively impacting resident care and quality of life. And that's the last thing that I will read today. Today's webinar, Optimizing Documentation to Improve Patient Outcomes and Mitigate Risk. We'll go over the session, the presentation in a minute and who the speakers are. Just let me do something here. So these are the learning objectives. There are CEUs, by the way, for administrators, nurses, and social workers as case managers in the state of Minnesota. And if you've applied for CEUs, you'll be receiving a certificate within 10 days after the close of this webinar. The learning objectives for today's presentation are to identify the most common factors that lead to fall-related litigation, including environmental hazards, policy gaps, and staff response issues, explain how documentation, reporting timelines, and communication practices influence legal risk and claim outcomes after a fall, and apply risk reduction strategies that improve fall prevention, strengthen compliance, and support defensible post-incident processes. Next slide. These are our presenters today. Amy Stewart is the Chief Nursing Officer for the American Association of Post-Acute Care Nursing, APACN. And Catherine Sullivan is a partner with the law firm of Kaufman, Borgeest, and Ryan, practicing in the fields of medical malpractice, skilled nursing, assisted living, home care, and hospice. She's based in New York. I want to say a little bit about Advancing Excellence before we get started. Advancing Excellence will be celebrating its 20th anniversary this June with a reunion of many of the past chairs and other individuals who were involved in its founding. We've been around for these past 20 years, and we initiated the Advancing Excellence in America's Nursing Homes campaign, which was funded by the Commonwealth Fund and supported by CMS. We did that for a number of years and made available to nursing homes across the country evidence-based performance improvement tools, which they could download for free from our website and then upload their data around clinical goals as well as organizational goals. Very successful campaign. At one point, over 60% of the nursing homes in the countries had registered for Advancing Excellence. And then we pivoted away and formed the collaborative, and we've been doing the work that I described earlier for the past several years. Just one more thing that I'll mention before we get started. The next webinar is June 3rd, and the Spotlight series is Person-Centered Care. Isn't that what we've always been have done? The presenters are Dee Cateau, who's the CEO of AG Rhodes. Um, Lacey Cornelson is the current director of the Kansas Peak Program and the Kansas State University Center on Aging. And Susan Ryan serves as the CEO of Aging In, formerly the Center for Innovation. And the moderator will be Barbara Bowers, another one of our past chairs. And as I said, that's up for registration already from our website. And it also will be offering one CEU on June 3rd. So let's get started. The next slide. So I've already introduced Amy and Catherine, and you can take it from here.
Thank you, Jay. Catherine and I are going to be sharing our expertise in two different manners, actually. I'm going to be sharing the clinical while Catherine is going to be sharing the legal aspect. And before we get started, if you would just put into the Q&A, what is one thing you really want to walk away from today's session knowing? What do you want to learn? What is your goal for today? And then Catherine, if you want to add anything.
Yeah, absolutely. Thanks, Amy and Jay, for the kind introduction. And, we look forward to having a conversation with you. Even though we can't see you, please feel free to enter anything into the chat. There are a lot of slides to get through, and we may not touch base on all of them, but we hope to give you some valuable information today. So, pleasure to work with you, Amy, and look forward to this topic.
Me too. Thank you, Catherine. Just to kick us off, I just wanted to remind people of some of the fall-related litigation that is out there, and Catherine can speak more to this. But I also wanted to share that the OIG has put out some numbers related to falls, and between July 1st of 2022 and June 30th of 2023, there were over 40,000 falls with serious injuries in nursing homes. So nursing home related falls are a really big risk area.
Yeah, absolutely. And they're big risk in terms of what we're dealing with in terms of litigation. Certainly, the numbers here, calling out Florida, we're calling out Illinois. It's no different in New York. Nassau County jury awarded punitive damages against a nursing home here, and that was sustained, upheld by the trial judge. And that was on top of an award for pain and suffering. So this is something we're seeing across the country in terms of the risk from the litigation end. And we really have to deal with that through strong documentation, pre-incident, meaning our charts have every intervention that we are actually carrying out, like you'll hear from subsequent slides. But also pre-incident in the sense of, are we talking to the family? Are we setting expectations? And finally, post-incident, we want to make sure we have all the statements in order because juries are not going to be forgiving if we do not have the documentation to show we are doing everything we are supposed to be doing.
Catherine and Amy, this is Jay. Most of the questions asked are, how do we get people to document more?
Yeah,
So I think
that is an
you're
excellent.
on the right webinar.
Yeah, that's an excellent question. I will start, and I think Amy will then smash it out of the park. But I will say, um, if you work long enough in skilled nursing, eventually you or your colleague will be called to give a deposition in a case that involves either a pressure injury, a medication error, or a fall. And you only have to sit through one deposition in your career to understand how important it is that you have a chart to show that you've provided the care that you actually did provide. Because when you testify, for a lawsuit, it is generally 2 to 4 years after the incident at issue. And you've cared in between for hundreds of people and you've provided quality care. And if you are faced with a chart that doesn't explain what it happened on that particular day, it's very, very challenging to remember, if not impossible. And the deposition can be quite painful. And so, uh, hopefully, if you are not gone through the deposition, you have somebody on staff, somebody who has had that experience. And I would strongly suggest that, after the lawsuit is wrapped up, whether it's through settlement, dismissal in the courts or trial, that there is conversations within the facility that addresses how important documentation is, not just to show, we've met whether it's DOH requirements or we've provided an accurate chart for a family and, pre-suit record request, but actually, their personal experiences on answering attorney questions that go to the care that was provided. That's the answer from a litigation perspective, but Amy, I'm sure you have more to share.
So, this is such a loaded question, to be honest with you, because I'm going to I'm going to stay focused on fall related documentation right now. And fall fall related documentation starts at admission. I have seen charts where the initial assessment may say someone hasn't had a fall, but the actuality is they've had a fall in the hospital or they had a fall pre-hospitalization. And so right out of the gate, our assessment is incorrect, maybe our initial MDS is incorrect then, and that changes their risk score as well. So documentation starts on admission and making sure it's accurate. So it's not just asking the resident who may or may not want to say, hey, I've had a fall, but also asking, the family members, has this person had a fall? Looking at your documentation from the hospital. And then looking at documenting the specific risk factors for this individual resident, as well as care planning for those specific risks. So if my fall is related to improper shoes, reminding me to use the call light isn't going to fix why I fell. So you just have to be so mindful, looking at the risks, documenting the risk, explaining and I think Catherine's going to talk about this. I think it's really important to document conversations with families about we can't stop your individual family member from falling. We can put all of the measures in place, but people are still going to do what they do. And so don't set no falls as an expectation. You're just trying to limit and mitigate the number of falls and the injury. And as far as how do you get individuals in your facility to actually document this? I like the idea of having a fall documentation kind of workshop that you put people through. So what does that look like? That looks like we take a fall, an incident that occurred, and we walk through it. Where did we go right? Where didn't we go right? And what are we going to do that is differently going forward? And have the nurses walk through that to see, because it's not an organization issue or a facility issue. It's also a nursing issue as well. So you can be called to testify to, you could be named in the lawsuit. And so you really want to have complete documentation. And sometimes I feel like nurses, we forget or time goes by and, we forget these little things, and just really walking through that kind of documentation fair, if you will. And I suggest this not only for falls, but also for pressure ulcers. Anything you want to add?
No, I think that's a great suggestion. Um, Sometimes, we can sense when a lawsuit is going to be filed, and by we, I mean the facility, right? The
Hmm.
staff know and have a sense. And at that point, it's making sure, before the pre-suit record request comes in, is the chart complete? Do we have all of the statements from staff? Because we don't know who will necessarily be designated to give testimony, but if we have, all of the aides that are on the unit that have said where they were standing, because that information is not going to make its way into the chart, that stuff we can collect now. We can put that down in writing. We can save that, for the facility in the event of a lawsuit. And so, it's a multi-prong approach of, do we have workshops? Do we have audits? But I
Yes.
think talking about the importance of documentation, talking about after a lawsuit has wrapped up, after an incident and investigation, just making it part of the culture to talk about documentation and that it's being done, is going to help raise awareness.
I think on this next slide, you could almost use this as kind of a checklist, if you will, of areas that you want to look at and document on. Some of them are some of them are risk factors, some of them are risk factors for a specific fall related incident. But you could use this as kind of a checklist of, hey, these are the things we want you to document on. What are does this person have arthritis? Are they on medications such as diuretics that may make them a higher risk for falls? What I already mentioned the history, but did they have a previous fall that resulted in an injury that now makes them deconditioned, which puts them at risk for future falls? So just, using this and then that post-fall analysis, which we both mentioned.
Yeah, absolutely. And this is a great checklist, and I think it's important to consider like what we can impact and what is something that is just going to be presented to us. What is this resident, coming in the door with? We can't change, what medications they're on, their level of competence in terms of are they following instructions? Can they ask for help? Are they able to physically or mentally? Can they remember instructions? And then there are things we can change, like our post-fall analysis, our interventions, our staffing, or at least the documentation as it relates to staffing, so that we can preserve that information post-fall. And so taking a time to evaluate each of these factors, I think will ultimately help in reducing the risk or finding out where we can like shore up the defense in general.
And you just brought up a really good point, and that is analyzing risk. We know falls happen, and looking at, do you have patterns? Are they on a specific unit? Using the investigation, putting interventions in place, educating staff. I am a huge root cause analysis person, so I would say use root cause analysis for every single fall that you have. Why did this happen? And sometimes we might think it happened because somebody didn't have their slippers on, but realistically it was because there wasn't staff. I actually had this happen. All of the staff were on break at one time and someone needed to go to the restroom. So again, that was a process issue, not just a people issue. So looking at your processes, and if we had not done a root cause analysis, we wouldn't know that. And where you're going to find some of this data for that is like in your fall logs and your incident reports and your maintenance grievance logs. And I just wanted to also say for those of you who are new to a facility, you might think, well, we don't have falls right now, but look at your delayed reports. So look at the 5-star. Was it a problem in the past? Your quality measure, your previous MDS data, so that you know how at risk your facility really is. I don't know if you want to add anything, Catherine.
Absolutely. I'm in terms of, the real-time data, this is all important things to consider. And, each state is going to have its own laws in terms of what is discoverable and what isn't discoverable. So if you have, counsel within your state and you want guidance, I'd suggest you speak to, an attorney in terms, but all of this is information that's important to gather, regardless of discoverability, and to reduce risk long term, we need to evaluate our process. And so, we have to take both a short, picture, right up front, what is happening, how are we going to deal with this lawsuit, what is going to be discoverable and what's not. For in New York, for example, we can have a root cause analysis if we have a falls committee and we can show that this committee meets regularly and it's to evaluate the process and put measures in place to reduce the frequency of falls. That's more likely to be protected, not guaranteed depending on your particular judge. Whereas incident reports are most likely in New York to be discoverable, but incident reports are often incredibly helpful because it's there we find the witness statements, information about aides and when they last saw the resident, documentation that is not going to appear in an EMR. And so getting those incident reports together are crucial, and making sure that whoever is filling them out, they aren't just checking boxes, right? Like, so if your incident report form has like 18 different boxes to check, is that form updated? If your facility has certain um, interventions that maybe are no longer used. I've seen the outdated interventions that have to do with side rails on a post-fall assessment, and that box is or isn't checked, and that can be a tool used by a plaintiff's attorney to kind of manipulate whether or not that's an appropriate intervention or an intervention that should be used. So maybe taking a good look at any form incident reports you're using or asking staff to fill out and seeing whether or not they need to be updated.
Amy and Catherine, just two questions that came up, and
Sure.
I'll just first one was, is charting by exception a better approach? And the second one is, this is from Dan Heimowitz, Dr. Heimowitz, agree with the process and root cause analysis. I might recommend that if a problem is discovered with a fall, for example, bad footwear, it would be good to proactively check everyone else for the problem
Yes.
in this instance and check everyone's footwear.
Absolutely. I think we both
Yes.
agree in that second point for sure, right? That's an opportunity. Go ahead,
Y-
Amy.
Yeah, no, well, I was going to take the last part first. That is that is excellent advice. When you see, for example, another example would be, let's say we have a handrail issue in a bathroom or something to that effect. And you think, well, your mind goes to, well, this was just an isolated incident. Well, the reality is you don't know it's an isolated incident until you do a sweep of the house. Root cause analysis. Tell me the first part of his question again, Jay. Sorry about that. I was very excited about the second part because that is so, whenever there's a problem, always, always check. And that's part of ensuring that you don't get cited too for something like this. Like you can do a past non-compliance and make sure you do a sweep of the house. Go ahead, Jay.
So the question is charting by exception a better approach?
Ooh, I
That's a
will,
tough one.
yeah.
Yeah, I don't know if there's a right or wrong answer, unfortunately. I will tell you, juries don't like it, and opposing counsel, the plaintiff's attorneys, um, are all trained to say if it's not documented, it's not done, right? So, of course, our job in prepping and defending skilled nursing facilities is to explain the reality and have our witnesses and nursing staff prepared to speak on. The reality is, sometimes we are, or most of the time at the facility, we are charting by exception. Um, but I'll tell you, like a jury does not want to see nothing in the progress notes for 5 days because they're just going to use that to say nobody has eyes on this particular resident. We all know that's not true, and we know there are many places in the chart we can look to say, well, of course care is being provided. We look at the ADL log, we can look at the MAR, right? But um, a jury's not going to understand it or appreciate it. And charting by exception just loses them little bits of information for a lawsuit that we can use to help show, the quality care that was provided. Um, I miss the days of handwritten records where you could really get a sense of a resident through progress note, but we don't have to lose that entirely in an EMR. There are, times when you can document things that may seem in the moment to not have significant meaning, but 3 years later are really helpful and refreshing recollection. If you're documenting about non-compliance, for example, and then what staff is doing to address that, whether it's education, communications with the family. If we're only charting by exception, I do think we're missing out on opportunities to help support the defense of the facility at a later date. So I'm more in favor of more documentation, although certainly the reality is balancing that with patient care. What do you think, Amy?
So that's interesting because I am not a fan of what we call UDAs or the checkbox assessments because it might tell me you have a problem, but it doesn't tell me necessarily what you've done. So, for example, um, I might check a behavior, but I don't know what the behavior is. And that documentation is not only important for litigation, but also for a plethora of other things, including like regulation. Um, so as you said, charting by exception, I don't really feel like that you can use it, but I don't feel like it's as popular as it once was. And where we really miss the mark when we do this is what is exception? So if I yell and scream every day, it becomes my norm and not an exception, and then it doesn't get in the chart. And that's the type of thing that bothers me about charting by exception is it's kind of subjective. Is this an exception? And you are, like you said, you're missing those little things that might give us a clue to what we're leading up to. Um, Maybe they have something, a changing condition that we could have picked up on 3 days ago if it was more detailed in the written notes, as you said.
Yeah. I mean, I remember before EMRs were widespread, we had more preservation, at least, of the 24-hour report or the shift-to-shift
Yes.
report, which we don't see as often in litigation, whether, they're not preserved or they're not used in the same way by many of the facilities. And so if we do not have detailed progress notes, and I'm not talking about every single shift, but at least, once a day, what's going on with this resident. I think that's generally going to be exploited by the plaintiff's attorney at the time of a lawsuit.
Hmm. I'm going to
Yeah.
just
But
move
I
on.
agree with you 100%. Lois, real quick, we don't
Yeah.
want copy and paste notes.
Oh,
That is worse than,
yes.
no in some cases because those become outdated and can be actually more harmful for a litigation perspective than a no note.
Especially if there's a misspelled word. I just want to throw that out there because I do see that as I still work, you know, occasionally as a nurse consultant, copy paste and one word is wrong and it's wrong throughout the whole, month. So, and there's ways of picking up on that in the back end of many or most EHRs. So,
Yeah.
just kind of moving through the slides, if you have, before we get to where we're talking about real, the documentation on a fall, just trying to give you some ideas of patterns and trends to look at to see if how widespread your problem was within your facility. So these are just some examples of where you might look for patterns and trends in your facility to see if you have a problem with falls. Um, and, before we get down to the individual person, I don't know if you want to add anything here.
This is I think, a good reminder as a previous slide where it's just if you're going back to your facility to roundtable some of these topics or ideas, this is one to come back to in terms of, a QA committee meeting.
Hmm. And also looking at your mitigating risks. How are you using your data? Um, to really, really help you identify and prioritize risk within your facility, not just falls, but and I think the one thing I really want to emphasize on here, and then Catherine, I'll turn it to you, is I see a lot of fall assessments where the person is at risk, but then the interventions that hit the care plan don't match the risk areas, or the risk areas specifically are not identified. So I think that's really, really important to look at that. And this in the second piece, I guess, before I turn it over, is you need to collaborate with the entire interdisciplinary team. So it could be you need therapy. Don't forget therapy is a big help in identifying deconditioning and working with the person, social services, activities, and dietary, all of them working, all of you working together to help mitigate falls. So if we know falls happen right after dinner for someone, maybe that's when we plan an activity. If we know it's before, maybe we have like appetizers. So there's some activity, we work with dietary to have like appetizers or something going on so that we're keeping people busy rather than just letting them sit. And Catherine, I'll see if you want to add
Yeah,
anything.
I want to add to the point you made, Amy, about collaboration. I think that looking at a chart, it can come across as if we're all like documenting in silos and we're all in our own separate section of the EMR. And we're not taking an opportunity to step back and consider, updating documentation, whether it's and updates to the care plan or making sure our progress notes reflect. For example, collaborating with therapy. We have residents come to us after a hospitalization. They're in therapy, they're making progress. Is it still appropriate to have certain interventions on our care plan after 2 or 3 months of physical therapy, and a patient is now ambulating without the level of assistance that they were when they came to us? And so it's great to use, care plan meetings as an opportunity, certainly to update the care plans, but would suggest that, don't wait for those specific quarterly meetings or, significant changes to update our care plans with appropriate interventions that are happening real time based on what we're seeing in terms of therapy. Or, it could be social work, for example. We know that resident behaviors can change after some time at the facility, and behaviors certainly lead to increased risk for falls. And are we documenting, whether it's in a behavior care plan or a fall risk care plan or in the progress note section, what kind of education we're doing, what kind of social support we're providing, what kind of emotional support we're providing, all of which is going to reduce the risk of behaviors and by extension the risk for falls. And so thinking about collaborating, which we're already doing at facilities, but how can we make and translate that collaboration into our documentation is something that's really important to consider.
Absolutely. And making sure it matches as well. I think that's something, sometimes there's a mismatch. Nursing might say one thing, therapy, they might be doing something different in therapy, which is okay, but then we still need to explain why that might be. Maybe they haven't graduated to that level of independence with staff. So I think I just wanted to point that out as well.
That's a huge point. And I know we're here to talk about falls, but let me take that opportunity to mention really briefly. We see
Yeah.
that often in charting for, pressure injuries, for example, where we have patients coming in from the hospital. Now they're our resident. Their ability to move around, be mobile in bed is going to significantly impact their risk for pressure injuries. And our documentation may be inconsistent with what PT and OT are documenting in terms of what they're seeing in therapy. And we want to make sure that if there have been actual improvements in their mobility in bed, that that is translated into the ADL section of the chart, that it's translated into the care plan section of the chart. So it shows actually this resident can, in fact, be mobile in bed independently. Or, as Amy's saying, there is a disconnect, but it's understandable because what
Mhm.
staff and the level of staff is providing, or the independence of the resident on the unit is going to be different than it is when they're PT or OT.
Perfect. I couldn't agree with you more. Just really quick, talking about the risk assessment. I think we've really touched on this, to be honest with you. Just making sure that I think the only thing I really wanted to add here is making sure that your current fall risk assessment is evidence-based. I believe that most of you are using an evidence-based tool. But every once in a while, I will see a UDA updated to a fall assessment that I'm unsure of where it may have come from. So you want to be making sure that this is a clinical evidence-based practice based tool that you're using. Uh,
Sure.
and
What we see from the litigation end of risk assessment, the fall risk assessment, and breeding risk assessment is they change over time. And that is common, right? It can depend on how that resident is doing a particular day. It can depend on factors like we talked about PT and OT, or maybe their own diagnoses or medications are impacting their level of risk. When the risk number changes, the plaintiff's attorneys are immediately looking into the care plan and saying, aha, the risk changed, but the care plan didn't. And so we want to make sure, right, in terms of consistency and what we were just talking about, that when our risk assessment is done and there's a increased risk or less of a risk, that we are showing, whether it's we're showing the Department of Health or we're showing our adversaries, we're showing a jury, we're demonstrating to a family who's asked for their records, considering a lawsuit. We were evaluating risk and creating an individualized care plan, and that care plan was updated based on the changes in this resident's risk profile.
I think now we're going to get into what people really want to hear from you on, and that is the chart and the quality of, what is in the chart and how it demonstrates the quality of care delivery.
Absolutely. We talked about it already a little bit. It's not documented, not done. I suppose that is something you have heard before. Um, it is something that a plaintiff's attorney will question your staff about at a deposition. And the jury, this day and age, they want to see the evidence. They don't want to just hear the testimony. They want to see on the screen your health record, your EMR, and they want to see proof, evidence that you provided the care that you said was provided. And the chart is the place to showcase that. So missing documentation, in, care plans that are incomplete. These things are almost always going to hurt the defense. And the chart is essentially the defense for the facility in a lawsuit. Yes, we have incredible staff, but we also can't control turnover and we can't control timing in terms of the lawsuits. And so some of our nurses may retire, they move on to different facilities or a different area, they may move on into a different career, whatever it is. We are not going to necessarily have the same providers available for trial that were at the facility years prior. But we have the chart. And so the chart is going to be the focus of the defense. It's what the experts are going to testify to. It's what your witnesses are going to rely on, meaning your staff. And it's what we as attorneys are going to use to show and prove to the court and to the jury that the care we provided, met the standard of care.
Excellent. You touched on this, but addressing the behaviors and related to falls, um, do you want to expand on any of this a little bit more?
I think it's important to call out education, and
Hmm.
especially at admission. There are conceptions in the general public that if you bring a loved one to a nursing home, they are not going to fall. That is not reality based,
Yes.
right? And so our job is to educate the resident and to educate the family, and frankly, to educate, just the general public through those that are coming to our doors. But we can do everything we will do everything that we are allowed to do, but there are limitations, right? And so we can't do everything to prevent a fall, and we can't guarantee that the falls will not occur here. If mom or dad fell at home, if they fell at the other 2 or 3 nursing homes that they were at before they're at your facility, they're probably going to continue to fall. And so we have to educate family on the fall risk and what staff can do, but also what we can't do, right? And
Hmm.
so, what is common sense to us in the industry is not common sense in the general population. The concept of physical restraints, chemical restraints. Why can't you just use a seatbelt on the wheelchair to make sure, my mom or dad doesn't get out of their wheelchair? We have to educate family at the outset, what is allowed under the regulations and what isn't allowed.
Hmm.
We have to explain why we may be um, providing side rails that are different from what they see at a hospital and explaining that. And sometimes it's not enough to just tell a family, well, we can't do that. We have to explain the why. So I encourage your facility to have these conversations with family members at the outset, not just after an incident, in which case it comes off sometimes as defensive. What do you think, Amy?
You know, the one thing that stands out to me when we talk about relationships with family is getting to know that leadership team from day one. So I'm going to share an example. I put a friend of mine, I was her healthcare power of attorney. She went to a nursing home. The dietary person, the activities person introduced themselves, but the nursing department did not. And so I felt a little disconnect there. And I thought to myself, how am I supposed to trust the clinical judgment of the nurses? Because she was there for nursing related reasons, for chronic conditions. And I thought to myself, how could, how would I have liked to have seen this? And what did I do as a director of nursing? And looking back, I realized I found great joy in meeting people day one, day two, and building that relationship, not only with the resident, but with the family, so that they trust me, that they know my door is open, that they know they're going to see me on the floor. And I, th I've heard, and so maybe this is a question back to you. I've heard that building that trusting relationship really can help lower the risk of litigation. Thoughts on that?
Yeah, absolutely. There's actually, conversations, studies that are ongoing in terms of communicating openly and honestly with families before incident, but even after incident. And
Yeah.
certain states have different laws. So there's, apology laws that are vary state by state. In some states, a post-incident apology is discoverable, and in some states it's not. But the research is trending and showing that open communication with the family, explaining what happened post-incident by the appropriate person after a complete investigation does help reduce the risk of litigation. And I would say having those conversations before an incident is even more powerful. When you can build trust, when you can explain what the facility is doing to address and reduce the risk for falls, but what the facility is also not doing and why they're not doing it. And by that, I mean, physically restraining a loved one
Mhm.
to a wheelchair or a bed. Sure, it can increase well, let me say that it'll decrease the risk of falls, but it's going to increase the risk of other injuries. And apart from being, um, a clear citation by a Department of Health, certainly, but explaining to the family that there's value in having loved one up and ambulating on the unit, and here's what we do to monitor, but also setting expectations. We don't provide constant one-to-one monitoring, and why maybe that would not be appropriate in a certain situation. Having these complete discussions and then documenting the conversations do reduce the risk of, confusion and taking a lot of depositions of family members over the years. I often hear that um, lawsuits are filed because the family just wants to understand what happened. Not many families are looking for compensation. There are plenty of billboards. We all pass on the way to work. However, many families just don't understand why their loved one fell, or they feel that the facility was not being forthcoming with details, and a lawsuit is their only way to get an answer, or that is the impression. And so if we have these conversations, if we educate, we teach the family members what we are doing and why, and what happened post incident, I do
Mhm.
feel that overall we're going to be reducing the risk of litigation.
I, I'm guessing, but maybe it's just me. I'm guessing that somebody probably has the question of, so instead of apologizing, is there a better way to frame this rather than apologizing? Since you can't know all states, what the ruling is there, is there a better way to explain this to the family when,
Yeah,
post incident?
absolutely. Absolutely. Post incident, the conversation with the family should be one that's prepared for. There's the post incident phone call, certainly. We immediately have to report, there's a fall, your family member has been transferred to the hospital for further evaluation. Uh, and at that point, we don't necessarily have to share details because we probably don't yet have a full picture of what happened. And so would say that it's the post investigation
Mhm.
conversation when the resident is either returned or the family is calling and asking questions that we sit down, we have a meeting with, whether it's if you have a risk team or you have interdisciplinary team that addresses these issues quarterly. You may call like an ad hoc meeting to just address this particular resident's incident, evaluate what happened, what interventions were in place, why those interventions were appropriate, and that, this fall occurred nonetheless, or what interventions need to be added. Go into that conversation prepared to answer questions, but with the understanding it's potentially going to be recorded. Each law has each state has different laws on recording conversations and whether you're a consent state or not. I think it's just best practices to understand people are recording nowadays, but it doesn't mean we should shy away from these conversations. People do want to understand what happened, and if we can present to the family right away We provided this care. We're very sorry that this happened. We're here, for your loved one's return and rehab, and here's the interventions we had in place. Here's the monitoring that was occurring as a matter of practice, and here's what we're going to do going forward. We can't guarantee a lawsuit won't be filed, but we can reduce the risk. And if we have that conversation in a prepared manner and presented by an appropriate person to the family member, that's information that's eventually going to be discoverable in a lawsuit anyways. And so why not get that information out ahead of time to the family in an organized manner? Lots of facilities we work with here in New York will, reach out and ask for counsel, before a lawsuit's even filed, and that is something to consider if you know you're dealing with a litigious family. But it's a conversation that is, in certain cases, worth having.
Excellent. Thank you. Anything you want to talk about regarding myths and reality?
Yeah, I think we talked about this a little bit a few minutes ago, which is just education. What we understand working day in and day out in the healthcare industry is not the concept or the impression that your average person has of a nursing home. The understanding is, I'm going to bring my loved one to this facility. They're not going to have any falls. They're certainly not going to have any pressure ulcers. They're going to be safe and they're going to live forever. And the reality is we have to set expectations. And so if there's a resident coming to us that has a history of multiple falls, falls at home, falls at other facility, we should be explaining, we don't provide one-to-one monitoring here. Here is what we do provide. Here's the level of assistance and support and observation monitoring. So we can set expectations right away. It's important to ask the family, what are they expecting? What
Mm.
are having those conversations? And then documenting that those conversations occurred and what was discussed, whether it's the social workers know or a nurse that's going to be on that unit regularly and really know that family. Is this the idea of setting expectations? So seatbelts, in addition to monitoring, is a huge one. Side rails, the use of medication appropriately and inappropriately. These are all things that are common sense day to day for us. We may not even really talk about it on the unit because it's just so commonplace, but it's not necessarily commonplace for the family who doesn't have experience in long-term care.
And if I could add, uh, when I was a director of nursing, I had a situation where we had a family that was unhappy with pretty much everything every single day. And when I looked at what was going on underneath the surface, I was able to look at the situation from a completely different lens and share this with my staff as well. This was someone who had been given a very terrible diagnosis, had just retired, had planned to travel the world, had plans set in motion. Family could not accept that this was their fate. And instead of looking at it from them attacking us, like the staff, I started looking at it from their standpoint, their loss, and would document all of the things that they said to us. And I think it really helped. We never, after I explained it to staff, staff looked at this family very differently. And it took me a minute too, because I couldn't, you can't believe it that your staff is being told that everything they do is wrong. But it wasn't that we were doing everything wrong. Sometimes you also have to look at what someone's going through and be empathetic and sympathetic towards their situation as well. And I think that your mind as a nurse, especially when we're in these confrontational, and we were in a confrontational situation almost every single day, I really truly felt that they were going to sue us. And in the end, they did not, which was just unbelievable. So I
Mhm.
just wanted to add that. And I think a lot of it had to do with being sympathetic. We've talked a
Yeah.
lot about the care plan. Um, so I don't know if there's anything else you want to add, but
No.
just yeah, I don't really have anything to add there. I thought we touched on this too, regarding welcoming the initial family contact, building that relationship. Is there anything you want to add here?
Yeah, I mean, I think this slide really speaks to the story you just shared
Hmm.
with that particular family, is that by building rapport, setting expectations, explaining the services that we will be providing, but also the limitations that are set upon us,
Hmm.
through regulations, through state laws, is critical. And then to document that, those conversations, explanations, communications with the family, these are things that we won't remember 3 or 4 years down the line. But if we have this documentation, and there is a lawsuit, we have a lot of ammunition to help support the defense. And if there isn't a lawsuit, you won't know that, but it could very well be like Amy's story, where we just have built rapport and trust such that, a family is going to feel, that the fall was unfortunate, but not necessarily because the staff wasn't providing appropriate care.
Absolutely. We've also touched on the family education that not all falls are preventable. And I've definitely seen situations where this is absolutely saved facilities. My own father was in a nursing home, and I know they felt bad calling us to say, he fell, he had dementia. Um, but, knowing the industry, and I would tell my family, they can't, there's no way for them to prevent every fall. And they did a really good job, I felt, of telling my mom, the things that they would put in place. So just making sure your family uh, understands, like you said, what degree of monitoring that a facility can do. It isn't realistic to do one-on-one. We can't restrain people without other, deconditioning or pressure ulcer risks, and just really spelling it out. And then I like that you put the hospital versus nursing homes. We are very different. This is more of a home-like environment, and understanding that we do not chemically or physically restrain individuals.
Yeah, absolutely. When, we have to take depositions of family members, they'll say, well, I saw the hospital did this with my loved one, and then they came to the nursing home and it was completely different. Well, there's also different regulations that govern nursing
Hmm.
home than the hospital, and nursing homes have various restrictions, and it's a home-like environment. But this is where it's incumbent upon the facility to really educate and communicate with the family so that they don't look at the nursing home and say, well, you weren't providing the same level of care as the hospital. Well, we aren't required to, and we can't. For, we're not. That's not what the nursing home is for. Um, so the only other thing I'll add to this is some of these points we make here are patient or resident specific. So like degree of monitoring, it's important to consider like how the patient is in terms of behaviors. If we have monitoring in place for a combative resident with dementia, like that monitoring should be different type of monitoring than maybe a resident who's alert and oriented on the short term rehab unit. Um, and also, how we're preserving the documentation for the monitoring. If we're charting by exception, there's going to be even less documentation, but even an RN note or a LPN note and the progress note every shift isn't going to necessarily be enough to show we were providing monitoring that was appropriate for this particular resident's level of needs. And so do we have, worksheets that show, hourly rounds, depending on the unit, there may be more frequent rounds, or post fall, if we have neuro checks, are we documenting that? And then are we preserving that information in a way that we can call back and provide that to counsel at the time of a lawsuit?
Thank you. I want to do a quick check because we have about 8 minutes. Jay, are there any questions that are pressing in the Q&A, or are there questions out there that individuals want to ask? Ev We've gone through most of the content on the slides, and I want to be able to be mindful of questions that people might have in the audience.
Okay, so I think one of them, fall interdisciplinary team documentation, your thoughts on that. Another question, and I think you did cover that. Do you recommend the Morse? Um, Another question, if a risk factor changed, but the score didn't, do we still need a care plan adjustment, meaning the risk score is the same, but a different cause now? And the last one is presenters' thoughts on poor grammar and notes For example, no periods, misspelled medical terms, all caps, non-standard abbreviations. Those are the outstanding questions.
Yeah. I could start at the end only because it's the most fresh, but poor grammar and
Yes.
notes, it's a problem when there's copy and paste, like Amy was saying earlier, right? If you were highlighting certain text and then using that text to save time and put it in another progress note, and there's, spelling error, grammatical error, it's just going to highlight that the fact that our staff is copying and pasting. So that's very dangerous. But otherwise, you know, e even as, as counsel, I would take a note with, misspelling any day as long as it's an individualized note. That is not, we can always deal with that. We can't necessarily help or deal with missing documentation. Um, Commas and periods can be, I've had to produce witnesses where it was quite confusing what they did when in terms of monitoring, and commas would have certainly been helpful, but that is more played out in incident reporting, like witness statements, and not so much in the EMR. So I'm not particularly hung up on, all caps. Well, all caps can come off wrong. I should say that if we were having your staff type, all caps, turn in position or monitor, it can look like that wasn't being done. So I would caution there, but poor grammar, we really just have to watch out for copy and paste and punctuation. It's really, is it clear that, for example, if we have an aide who's doing a witness statement in connection with a fall, and they're talking about each time they have witnessed that particular resident on the unit, they stopped in for rounding, they stopped in for toileting, whatever it was. Make sure having someone else look at that documentation just to see that it reads in a way that makes sense and can be used later on. And then reading, doing that in front of the staff member, and if there needs to be clarification that can be done with this by the staff member in their handwriting would be my recommendation on that. Amy, anything to add on that particular point?
Not that point.
Yeah,
But
jumping
I
on
would t
another one then.
I'll take the care plan adjustment. So
Yeah.
if your risk score is the same, but in a different category, I always think that your interventions should address the categories that the change is in, meaning you want to show that you have interventions for the actual risk area and not, otherwise it looks to me like you just have canned interventions. So for example, if you told me to use my call, remind me to use my call bell, but I have a cognitive impairment, that is not really matching with resident specific or person-centered care plan. So I would say, yes, I would definitely review the care plan to see if there's any adjustments to the intervention. Regarding the fall IDT documentation, um, definitely, well, I think we touched on that. Definitely working together, making sure everything is on the same page as we said. And if we're not, for example, if someone can walk in therapy, but they're not walking with nursing, why not? And, when do we anticipate them to be able to do that? And then the other question, I think, okay, the specific conversations with family members. One of the things I want to say about this is if you're going to document, and I'll let Catherine mention this, but the one thing I find is that if you have a conversation and it says son and they have five sons, I don't know which son, and it makes it a little bit more difficult. Um, so, I like having the documentation. I've seen charts where the son had, for example, I just read it was a pressure ulcer case, but a family member brought in some AFOs that weren't prescribed and put them on. And, so it was and then sued for pressure ulcers later. So it was very clear who brought them in and it was the same person. So that documentation was really helpful, I think. Catherine, you can say whether or not.
Well, I want to expand. I terms of your answer on the risk factor changing and what do we do in the care plan, I absolutely
Sure.
agree. We need to review the care plan, and just because the score is the same, it doesn't mean that the interventions remain appropriate 100%. There are instances where the score may be the same, it may change, the risk factors may be the same, maybe change. We should still be documenting in the care plan that we reviewed it and that the interventions in place remain appropriate at this particular time. So that way, even if there's a change in risk factor, the score stays the same, or the score changes, we have demonstrated through our documentation that we've evaluated the change in risk. We've looked at the care plans and what interventions we're providing, and we have made a determination that these interventions remain the appropriate interventions for this particular resident. So it may be the risk factor changes and the care plan stays the same. Without that note into the care plan, and there's a note section for your care plan, use it, right? And it would basically say care plan reviewed, interventions remain appropriate. Sometimes with the call bell, with a resident who may not be alert and oriented or who has short-term memory issues, it's going to be difficult, but we can have the documentation that includes, remind or educate or, within reach. And it's not going to be, we're going to solve it all. But those are the issues that, plaintiffs' attorneys are looking at. And so if there's no mention of the call bell or there's no mention about education or reminding. They'll nitpick on these particular issues. And so we want to make sure that, yes, the care plan is individualized. If the risk changes, the score changes, that's reflected in the care plan. And if the interventions shouldn't be changed, that we've at least noted somewhere in the chart that those interventions remain appropriate.
I'm going to have to end the webinar right here because we're kind of over the limit. But I want to first of all thank Amy and Catherine for fabulous presentations. This is really a breath of fresh air, I'm sure, for many of the people who've been listening here today. I also want to thank Pathways Healthcare and Tekla Johnson, who is administering the webinar for Advancing Excellence. For those of you who go to our website, you can download the entire webinar, including the audio and the slides, and you can share them with folks in your facilities. And if there are further questions, you can put them in the Q&A, and I'll try to get them over to. So I see a couple of people are commenting here, but I think the remaining questions had been answered. So. Thank you again, Amy and Catherine and Tekla and Pathways, and thank you for joining us today, and you'll be getting more information from us. And within 10 days, you'll be receiving your certificates. Thank you all.
Thank you.
Great.
Thank you.
Thank you. All right.